Retina Rounds, episode number 154, Staged Diabetic TRD Repair. In cases of complex vitreoretinal pathology, sometimes multiple surgeries are necessary, and a staged approach may be preferred to safely return to the operating room when the eye is more stabilized. For example, in complex diabetic tractional retinal detachments, when significant subretinal fluid is present, there may be an increased risk for iatrogenic retinal breaks during membrane dissection due to the lack of underlying retinal countertraction. Now, in this scenario, a TRD may progress to a combined TRD-RRD, significantly increasing the case duration, recovery period, and potentially compromising the patient's anatomic and visual outcome. In today's case, presented by returning guest surgeon Dr. Jesus Maticorena from Peru, the patient underwent a pars plana vitrectomy to repair a complex TRD. Now, due to the presence of significant subretinal fluid, Dr. Maticorena performed limited segmentation and laser during the first surgery, with a plan to return to the operating room once the subretinal fluid had resorbed. This video picks up at the second surgery 6 weeks after primary vitrectomy, and remarkably, the retina was completely attached, allowing Dr. Maticorena to safely complete the surgical repair. Let's check out the surgery, and at the end, we'll discuss some pros and cons of the surgical approach. Okay, you can see here we're now 6 weeks after the patient's initial vitrectomy, and it looks like the initial vitrectomy was pretty thorough. There's not much vitreous here that's left behind. These temporal preretinal membranes look to be well segmented, don't appear to be applying too much traction over the macula, and there is a little bit of shakeout hemorrhage. But really the main reason for returning to the operating room is to complete the PRP, which Dr. Maticorena couldn't do during the first surgery due to the presence of significant subretinal fluid. And now you can see just 6 weeks after the first surgery, the retina is completely attached. Now, while he's here, he's going ahead and removing some of these residual membranes. Now, one could make the argument that this is probably not necessary. There appears to be significant ischemia. There's probably a significant amount of macular ischemia. But while he's here, Dr. Maticorena is trying to be as complete, as thorough as possible in removing these residual membranes. Now, once the segmentation and delamination have been completed, Dr. Maticorena is now going to apply the PRP. Now, he's also applying some laser around these residual pegs. That's typically not my approach, but perhaps he's concerned that there might be a small micro break in these areas. There is definitely a break in the nasal periphery, which has been lasered. And again, one could make the argument that dissection of these membranes in the nasal periphery may not be necessary. But now the PRP is complete. He's done an air fluid exchange, and that completes the case. Okay, so here's some take-home points. Staging vitreoretinal surgery in cases of complex vitreoretinal pathology can allow the surgeon to first stabilize the eye and then subsequently return to the operating room for safer final surgical repair. Now let's talk about some advantages to this approach for TRD repair. First, delamination and segmentation may be easier. Now, following primary vitrectomy and release of anteroposterior traction, chronic subretinal fluid may resorb, which makes dissection of preretinal membranes easier and safer once the underlying countertraction of attached retina has been restored. Now, while typically chronic subretinal fluid may take months to resorb, Dr. Matikorena's patient shows us that subretinal fluid may also resorb rapidly in some cases, allowing the surgeon to return to the operating room relatively quickly. Now, second, even if intraoperative breaks occur during the second surgery, if they occur in attached retina, they are generally easier to address and may be less likely to progress to a combined tractional and rhegmatogenous retinal detachment. Third, you can see from this case that Dr. Maticorena did most of the PRP during the second surgery, and when subretinal fluid is present, laser uptake may not be achievable, and increasing laser power or duration to apply laser in areas with shallow subretinal fluid can increase the risk of an iatrogenic retinal break. In these scenarios, it's generally best to apply the laser to areas of attached retina and then supplement the laser later on once that fluid has resorbed. And typically this can be done in the clinic setting and by itself would not require a trip back to the operating room. And if shakeout hemorrhage is present that obscures the view for laser, intravitreal anti-VEGF pharmacotherapy may be used as a temporizing measure to block ongoing proliferation until the hemorrhage clears and the PRP can be applied. Now, fourth, an added benefit of staging surgery is that any shakeout hemorrhage can be evacuated, and that potentially can expedite the patient's visual recovery. And last, in patients with significant cataracts, a staged approach with cataract surgery performed during the first surgery can give the cornea enough time to recover so that membrane dissection during the second surgery can be carried out more safely. Now, the main disadvantage of a staged approach is, of course, the need to return to the operating room. And in patients with significant medical comorbidities, the stress of multiple surgeries can pose serious systemic health risks. Furthermore, multiple trips to the operating room may not be possible in resource-constrained healthcare systems. And last, if the patient is lost to follow-up, which is unfortunately not an uncommon occurrence in patients with advanced diabetic eye disease, or if there are significant delays between the first and second surgery, incomplete surgery runs the risk of ongoing proliferation and potentially additional ocular complications. Now, taken together, my approach is to try to perform the entire surgery in a single surgical sitting. If the risks outweigh the benefits for specific maneuvers like membrane segmentation or delamination, I generally opt to do everything possible to stabilize the eye and live to fight another day, either with additional treatments in the clinic or return to the operating room. And as always, there's not a one-size-fits-all approach to TRD repair. The surgeon needs to use good intraoperative judgment to achieve the surgical goals without introducing unnecessary risk to the patient. And sometimes this is best achieved with 2 surgeries rather than 1. Now, this is a wonderful case to illustrate this point. We want to thank Dr. Maticorena once again for sharing it with us, and thanks so much for watching. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.